Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Hello everyone, welcome to a new year and to a new season of the Research Works podcast. Welcome back, Ash. I hope you've had a lovely Christmas and New Year.
Thanks, Dana. Welcome back to you too. It was a lovely Christmas, very relaxing time spent with family and friends, ate too many desserts. Before and after Christmas. So,
okay. The leftover game was strong.
Yeah. What about you?
Oh, look, I managed to get away for my Christmas. So this is the first time I got to go away for Christmas in quite some time. So just it's nice to experience Christmas in a different culture as well, like in a different setting. And yeah, so I went to Singapore. So lights galore, really.
Beautiful.
So it was wonderful. Yeah, thank you. It's nice to be back though. Here we go. Third season. Can you believe it?
I can't. And we are very, very privileged to be doing a third season of the podcast and even more so to have an incredible guest with us today to celebrate the start of our new season. We've been trying for a few months to find a time that works for his incredibly busy schedule, but we want to give a very special welcome to Professor Mark Bellgrove. Welcome, Mark.
Welcome.
Hi, guys. Thanks for having me.
Oh, very, very excited to have you. People who are in the industry will know that your name is coming up a lot at the moment with the most exciting release of the ADHD clinical guidelines. And so today is going to be a great opportunity to talk to someone who's been so involved in this process and the fact that it's now been publicly available and it's very, very detailed. So we encourage everyone to have a look at it themselves as well. But today, I think we're going to have a really good start at really just talking about what these Australian evidence-based clinical practice guidelines are for ADHD.
Yeah, but before we get stuck into the guidelines, and there is a lot to cover with those, Mark, we thought we would tell our listeners a little bit about you. So Professor Mark Bellgrove is the Director of Research at the Turner Institute for Brain and Mental Health, and a professor in cognitive neuroscience in the School of Psychological Sciences at Monash University, where he leads a multidisciplinary team studying the biological basis of attention and cognitive control. His work centres on understanding the neurobiology of cognitive functions, including attention, cognitive control and decision-making in both health and disorder, so attention deficit hyperactivity disorder and stroke. He's a Senior Research Fellow of the NHMRC, and his research work is funded by the ARC, NHMRC and the MRFF. He's the President of the Australian ADHD Professionals Association, a peak professional body for ADHD in Australia, and the project lead for the development of national clinical guidelines for ADHD following the NHMRC process.
I'm in awe already. Impressive.
A bit of a mouthful for you there.
That's okay. Dana always likes to get me to say all the big words in the introduction, so I'm getting my head around them slowly.
She's clued into it, and I always stitch her up for these because she's better at it than I am. And so, yeah, and there's a very, very impressive bio there. I mean, you know, for anyone who's involved in research to have things that are funded at that level, you know, speaks to the wealth of experience and knowledge, but also huge teams, right? Like you can't do this on your own.
Absolutely not. I've got a wonderful team at Monash and a wonderful team at the Australian ADHD Professionals Association also.
Yeah.
Oh, that's impressive.
And we look forward to hearing more about that in just a second.
Yes.
But Mark, that's the formal getting to know you part. The informal getting to know you is our little icebreaker that we like to ask everybody. And today's question, being the start of a new season and the end officially of our holiday period, is we'd like you to tell us about your favourite holiday. So that can be kind of a formal holiday like Christmas, or it can be just an informal trip that you've taken that you really enjoyed.
Nice question.
Well, my favourite holiday period is probably Easter, actually.
Yeah.
Christmas, I don't know, maybe I'm a bit of a grouch or a Grinch or whatever the term is. But I really enjoy Easter because my family and we go away and play a tennis tournament up on the Murray River, playing on the grass courts at Yarrawonga with a whole heap of mates.
Yeah.
Wow.
So we all pack up and trek up there and have a really great time.
Oh, that's brilliant.
That sounds like so much fun.
It does. It really does. It's a good time of year. Yeah.
Harder and harder every year as I get older.
And does it get a bit competitive, Mark? Are you playing for sheep stations yet?
Yeah.
We all love a bit of good competition. That sounds great.
Yeah.
But I like how you fit in, it's physical activity and fitness as well. It's not just a holiday. I love it. I love stuff like that. It's great. Well, I love these sort of questions, Ash. I think we'll reminisce about holidays a lot. My favourite holiday that I always think back to would probably be the first time I went to Tuscany. We were just there for 2 weeks with some family, met them there. So we had some family drive from the Netherlands to Italy. And it was just the best. It was just 2 weeks. It was sort of out, as you would imagine, with the olive trees and the grapevines, and it was just great pasta. And we just would have the lady who was looking after our apartment or house would come over every day and give us a new bottle of olive oil every day. So I was like, are we meant to finish a bottle of olive oil every day? Challenge accepted.
When in Tuscany.
Yes, exactly. So it was all very food-based, really, I'd have to say. But I love Italy.
Sounds like something out of a movie.
Yeah, it did feel like that. It was pre-PhD. So it was like, I remember thinking, this will be the last time it'll feel like that. But it was over a decade ago now, so I might need to go back. Yes. What about you, Ash?
Oh, well, my family celebrate Christmas. So for me, Christmas is a really fun time of year because work's kind of finished up for the year. And, for everyone who does celebrate Christmas, there's lots of beautiful lights set up in the houses when you drive past, and there's lots of yummy food to eat, and everyone just feels quite relaxed and happy.
The whole festive season, isn't it? Yeah. I like it.
There's a really nice vibe to it. So I'd have to say that's my favourite.
Oh, I like it. Well, Christmas comes by pretty quickly these days, so
sure
it'll come again soon.
Yeah.
All right. Well, now that we've talked about our holidays and we've planned for holidays for the coming year,
yes,
should we get into the podcast?
Let's do it.
Let's do it. All right. Well, let me give you a bit of a rundown of what we'll be talking about today. The Australian Evidence-Based Clinical Practice Guideline for Attention Deficit Hyperactivity Disorder aims to promote accurate and timely diagnosis and provide guidance on optimal and consistent assessment and treatment of ADHD. This guideline integrates the best available evidence along with multidisciplinary clinical expertise and lived experience, essentially the definition of evidence-based practice. The result is a guideline that outlines a roadmap for ADHD clinical practice, research and policy. There is just so much to discuss.
There really is. And thank goodness we have Mark here with us to do it.
That's right.
So Mark,
be careful what you wish for. I might get really carried away.
That's all right.
We love when that happens. That's so cool.
So Mark, as we've said a few times now, this is a massive body of work. So to give us a little bit of context, could you talk to us and our listeners about how this clinical practice guideline came to be? What started you off on this journey?
Sure. Well, I guess the starting point for this whole journey was actually when we established the Australian ADHD Professionals Association back in 2016. And that was really because at the time we felt we needed an interdisciplinary voice for ADHD, and we needed a group to come together that was really prepared to advocate for ADHD and also engage in this type of work, because there hadn't been a clinical guideline for ADHD that had been approved by the NHMRC.
Right.
So we set this on our agenda right from the very start as important work that needed to be done. And look, it has been a pretty amazing journey. The guideline was, I think, as needed and as much wanted by those with lived experience of ADHD as it is for clinicians. people with lived experience regularly ask me, when is it going to be done, Mark? When is it going to be done? And look, it did take a long time because we had COVID interruptions. So it was about a 2-year process.
Wow.
In terms of forming what's called the Guideline Development Group, which is the core group of people who do the work, do the voting, and do the writing. As you can see, there's lots of words in it, and they all had to come from somewhere.
Yes, that is lots of work.
It did feel like another PhD, I think, for a few of us. In terms of funding, it was funded because we were fortunate enough to get a grant from the Department of Health and the Australian government.
Wow.
And so we were able to use that funding to do this piece of work, in addition to other work that we've done at ADPA, such as the economic cost modelling of ADHD, which you may have seen, and some of your listeners may also be aware of.
Yep. Wow, it's such a huge body of work, and I guess that the reason why people are so interested in it is because, you know, ADHD is something that a lot of us have heard of before, and whether there's people who've lived experience or, you know, knowing someone that might have ADHD, you know, what are the current prevalent stats on that? You know, why is this such an important document?
Yeah, well, look, even before I address prevalence, I think we need to be honest, right? There's a lot of misinformation surrounding ADHD and a lot of myths. So I would hope that by reading this document and hearing podcasts such as this, we can engage in a bit of myth busting. Because really, there is strong evidence for ADHD, the diagnosis, the treatment. And I think it's really important that the public knows that, and that we can move and break down stigma around ADHD, because it really does affect the mental health of people with ADHD, like any other mental health condition, when stigma abounds out in the public. So in terms to your question, sorry, that was Dana, that was
we want to come back to that, though. We want to come back to that.
The international prevalence of ADHD in children and youth is about 5%, 5.5%. That's based on, you know, a lot of epidemiological studies.
Sure.
In Australia, it might be a touch higher than that. Some data suggests it might be around 7%, for example, from the Young Minds Matter study. And then in adulthood, the prevalence is about 2.5%. Again, based on international epidemiological data. We don't have great data on the prevalence of ADHD in adults in Australia. Certainly something that we need to do more work on.
Yeah. And just coming back to the point about, evidence, establishing an evidence base and the role of clinical practice guides like this one, I think we know that to be true for a lot of the other diagnostic groups that we've talked about before. I'm thinking about the clinical practice guidelines that exist now for cerebral palsy and autism, and as well as providing, I suppose, a clear guide for clinicians as to how to guide their practice. It really does help cut through a lot of that misinformation for families as well, doesn't it?
Yeah, totally. And I would hope that this is a really empowering document for people who have lived experience of ADHD, either themselves or in the family. And it really should enable them to be able to advocate for themselves in terms of which treatments they want to engage with, what is the evidence base for those. So I think it should equip them with a lot of knowledge, and it should hopefully be very empowering for them.
Yeah. And I think one of the things this guide has done really nicely is break down how to interpret the evidence for different types of interventions in ADHD in a way that is quite easy to understand, both for people with lived experience who perhaps don't have that background in research, but also for clinicians and researchers as well. So can we talk about how the clinical practice guide can be interpreted? So first of all, let's start with, I suppose, the certainty of evidence in what we're talking about.
Yeah.
So, and I should say this process that we followed is the process that is sort of mandated by the the National Health and Medical Research Council for their clinical guidelines, so that we stuck rigorously to that. So
it's a very important point.
So there's 3 classes of recommendation that we present in the guideline. The first is evidence-based recommendations. The second is clinical consensus recommendations, and the third is clinical practice points. So maybe I'll just drill into those a little bit more for you. So evidence-based recommendations really mean that we have scoured the literature for studies, for example, that have done randomized controlled trials of, one intervention over another, for example. And then we've been able to look at those data across a large number of studies, conduct a meta-analysis, which is a statistical analysis that allows you to work out what the likely effect is, the effect size. So how reliably does the treatment work over perhaps a waitlist control or another. And when we do that method, that evidence-based method, we are able to put a measure, or I guess, around the certainty of the evidence. So how confident can we be that evidence base is strong or not? And in the guideline, you'll see that for evidence-based recommendations, we also offer something called certainty of evidence. And it can be high, it can be moderate, it can be low, it can be very low. And then that gives the purpose of that was to give the guideline development group a steer, if you like, on the strength of the evidence. We then also engage in a process that's called grade, which is the way we come to determine what the GDG, the Guideline Development Group's feeling was for the strength of the overall recommendation. And so we can offer strong recommendations, for example. So in the guideline, you'll see things such as, for example, parent and family training should be offered for children and youth, for example. And this whole process really allows us to give both certainty and the strength of the recommendation.
That's great.
And for clinical consensus recommendations, what you're really talking about there is that we searched for evidence, but perhaps it wasn't, it didn't exist, or it wasn't particularly consistent or useful. So we would have conducted a narrative review prepared by sort of an expert subgroup of that guideline development group. And from that, then we derive further recommendations. And the third class of recommendation is something called a clinical practice point. And again, that was often in our GDG discussions, another point may have come up that was highly relevant, but may not have been one of our initial prioritized questions, for example. But nevertheless, the GDG felt it was important to comment on that. And so therefore we put those forward as clinical practice points. And what you can see in the guideline is that there are a lot of clinical consensus and clinical practice points, fewer evidence-based recommendations, but still quite a lot. I think there's 11 or 12, and they mostly are around treatment and diagnosis. It also highlights how much future research that we need to do to be able to provide the evidence base for. And so, a guideline, the whole process is tremendously useful for generating questions for future research.
And I really like that, this process that you've gone through helps clinicians to use the best available evidence. It's not just, obviously evidence-based recommendations are really powerful, but where there isn't the evidence base to be able to make those recommendations, there are other options to have the opportunity to get expert consensus and input into, how that fits best.
I think it's important to note that the guideline development group was very, very interdisciplinary. So we had psychologists, psychiatrists, pediatricians, speech pathologists, occupational therapists, pharmacists, etc., as well as representation from Indigenous Australians and those with lived experience. So it was from that sort of wealth of experience and that diversity, I guess, that we were able to put forward this broad range of recommendations.
Gosh, and I mean that just shows how relevant all of this is by who was able to put have the input into it as well. It's just such a great guiding document. So now that we've covered that, Mark, I really want to start going into I do want to start just by talking about ADHD because, like you said before, there is a lot of misinformation out there. When you gave the stats on the prevalence, I would say most people would be shocked and think, actually, that seems lower than I thought. I think sometimes people think it's much greater, mainly because I think the term gets thrown around. You see someone behaving in a certain way, they go, oh, that's ADHD. And I think that's what we want to talk about today. So what does it take to have a diagnosis of ADHD? And let's start there, then we can contrast it with what we hear about.
Yeah, no, totally. I think it's really topical. You've got, a large amount of what, people call self-diagnosis going on these days from TikTok, for example,
yes.
et cetera. And, actually, if you had a chance to view, you may not have yet, the video associated with the launch of our guideline in Perth, which was launched by Minister Butler, the health minister. I mean, he really made an excellent point in his launch video, and that is that what we're really about here is the appropriate, careful diagnosis of ADHD. People can have symptoms of ADHD, and they might do a rating scale, for example, and score up. But the important aspect for diagnosis that must be present in order for someone to meet criteria for ADHD is that those symptoms have to be having a functional impact on the person's life.
Yeah.
Right.
It has to be causing disability for the person. It can't just be the existence of some symptoms.
Yep.
And you think, oh, yeah, maybe I've got ADHD. There has to be impairment in multiple settings, whether it be school or home or friends' places for kids, whether it be the workplace, relationships, etc. For adults. The symptoms have to have a functional impairment. And I think when you double down on that and you do that appropriately, it does allay, I think, a lot of the concerns people have about diagnosis, and it means that the number who actually meet criteria will be a lot fewer than perhaps what the public might think.
Yeah.
And so those symptoms, can we talk a little bit about what those symptoms, what you might see?
Sure. So in ADHD, we have two what are called dimensions of symptoms. There's the inattention dimension, and the other dimension is the hyperactivity, impulsivity dimension. So inattention are the types of things that you probably may think about. That is, say, for example, a child who has problems sustaining their attention over time, perhaps in the classroom, perhaps particularly, when the class has moved on and is about halfway through, attention wanes over time. Others can be distractibility. Their attention is caught by things easily out in the environment, for example. The hyperactivity is often referred to as the child being driven by a motor, being constantly on the go, squirming and fidgeting in their seats and not being able to control their motor actions. And then the impulsivity can be the blurting out answers quickly without thinking, the problems taking turns, which can impact their social interactions, etc., can get them into strife if they don't think about their action and they've already thrown a rock rather than second guessing that impulse. And then those two dimensions allow us to define three subtypes of ADHD. You can have a predominantly inattentive subtype where your symptoms are inattention, but very few hyperactivity or impulsivity symptoms. You can have a primarily hyperactive impulsive subtype, which, as it suggests, is all about hyperactive impulsive symptoms. Or you can have combined type, which means combinations of those symptoms.
And, in hearing you describe those symptoms, that qualifier of it having to have a functional impact in, at least two domains or two aspects of someone's life is a really important condition, isn't it? Because all of those symptoms you describe, I think everyone can relate to at least, one or some of those in isolated incidents if it's something that you're not particularly interested in or,
I think it's really important that people appreciate that ADHD, perhaps more so than any other, developmental trait, is continuously distributed in the normal population, right?
Yes.
It is par excellence
Sure.
a quantitative continuous trait.
Yeah.
So, yes, many of us can do a rating scale and score up a few symptoms.
Yes.
But what we're talking about is the extreme end of that distribution where people have, at least 6 of the symptoms in the case of kids.
Yeah.
But they have to be having a functional impact and impairing their life.
Yeah.
Yep. And so along those lines of, the representation of what ADHD is in terms of getting a diagnosis, what would you say is the major harm in the misinformation that's out there about what constitutes ADHD? When there's so much talk about, I can often think about people in classrooms saying, oh, this kid's probably got a bit of ADHD. It gets thrown around in that kind of way. What's the harm in that?
Well, I think the most tangible harm is that type of language or that type of, belief can be very stigmatizing for folks that do actually have ADHD because, it is effectively downplaying the impact of that ADHD on people who do meet diagnosis for it. So I think, we do need to be careful about the language we use around ADHD, just as we do for any other mental health condition or neurodevelopmental disorder. Because language does matter.
It does.
And I think I've got a much better appreciation of that myself because of the involvement of people with lived experience in our own research in the work that we've done at ADPA.
Yeah. And just on that, Mark, I think it's either in the guideline itself or in the guideline summary, there's a table that actually talks through and provides a guide to language and, primary. So primary first language or identity first language. Could you just explain to our listeners, I suppose, the difference and then we can talk about, why that's important.
Yeah, look, that's been an amazing piece of work that was actually led by Lou Brown, who's from Western Australia herself.
Okay.
And actually even a PhD student at Curtin at the moment.
Oh, flying the flag.
Okay.
So you guys can fly the flag.
Connect,
and she is an appointed director on our board, ADPA board, providing lived experience perspective for us. And she developed that whole talking about ADHD guide, which is really brilliant. It's actually been translated into French and taken up around the world. So this is really about not stigmatizing folks with ADHD by use of our language. And the talking about ADHD guide goes through a whole range of recommendations. I can't off the top of my head remember how many there are, but about the appropriate use of language so that we don't feed into those stereotypes. So some things, for example, people will always talk about ADHD as a superpower, but for many people with ADHD, they don't feel it is. So it's better to not do that rather than, people often talk about, behavior, but unfortunately behavior always seems to imply bad behavior.
That's right.
So we're better off talking about symptoms, which are the appropriate way that's diagnosed. And people with ADHD, they're more than just their ADHD, right?
Yes,
so,
that's right.
They have, they might live with ADHD, but, they're much more than that. It's only one aspect of their life.
That's right.
Yeah. And there are some other, really nice examples of things that you can avoid or should try to avoid saying in relation to, or when you're talking about ADHD and some suggestions for the language that you can use as to replace that, which is, I find really helpful.
Really helpful.
And the other thing that I think is really helpful as well is that, just understanding that people with lived experience have a preference and in how they discuss ADHD and, your assumptions aren't always their preference. So just to be mindful of that when you're engaging in conversation about it.
And I think, it's been tremendously useful for workplace settings, that
Yes.
sort of information
Yes.
as well, so that people can be mindful of their language and its impact on other people.
Yeah. And I think people are increasingly more aware of that now, aren't they? It's like, oh, no, have I said it the right way? And so I really encourage everyone to look at Table 13. So, it's got some great things like, avoid using deficit, instead use difference or neurodiverse. Like it just comes up with a few things there that it'll be very, very helpful. And for teachers, clinicians.
It's also downloadable. It's also downloadable as a printed flyer from the ADPA website.
Oh, wonderful.
If people wish to go there.
Oh, fabulous. Now, I'm glad we were able to cover that. So now let's get into a bit more specifics about, some etiology about ADHD, because I think there's a lot of myths around that as well. Can you just go through, what do we know about the etiology, I suppose?
Sure. Well, we know that ADHD is a highly heritable condition, meaning it runs in families, and the heritability estimates are, very similar to other conditions that we now, acknowledge a strong biological contribution for, such as schizophrenia or autism spectrum disorder. And recent large-scale international studies now have identified genes for ADHD. And these have now been used to try and understand, the mechanisms by which ADHD might develop. Yep. A lot of work in that space at the moment.
Yeah. And, contrary to what some of our younger generation might think, it's not, diagnosing ADHD is not as simple as watching a TikTok video and thinking, oh, yes, that sounds a lot like me, or filling in, a screening tool that you might find online. Can you talk to us about how complex this process of getting a diagnosis is?
Yeah. Look, screening can be the first step. So if someone does do a screen and they score up as having, high symptoms on one of those sort of inventories or questionnaires, then the first step is a trip to your local GP, who are also increasingly becoming interested and aware of ADHD, lots and lots of interest from GPs. They will then refer to, if they think it's warranted, to a specialist who can diagnose and do a formal process. In childhood, the specialties that can diagnose are pediatricians, child and adolescent psychiatrists or psychologists, and in adulthood, it's adult psychiatrists or psychologists. And the process involves a very detailed, structured interview where questions will be asked about symptoms and whether the symptom threshold is met. But then there'll also be a whole range of questions about the functional impact that those symptoms are having on their life, whether the extent to which it's been a persistent effect. If it was an adult, was there the presence of these problems in childhood, for example? Can you give me any documented evidence from school reports that you had symptoms of ADHD in childhood, for example? Can I speak to your parent if they're still alive? What would they report about your childhood? And they'll also ask, a clinician would also ask a lot of questions about other aspects of your mental health, because we know that ADHD is highly what's called comorbid with other conditions. And those conditions also need to be managed, because that complexity will impact the person's mental health, and we need to know about all those other things as well. So, for example, in childhood, it may be autism spectrum disorder. It could be other learning problems like dyslexia. In adulthood, it might be depression, anxiety, etc.
And Mark, we know from other, facets of child health research that identifying and diagnosing early means that you can get the right supports in place, which, ultimately leads to better outcomes for children and their families. How early can you, I suppose, detect and diagnose ADHD?
Well, the diagnosis needs to be before 12. There will be certainly kids who will display symptoms early in life, but, usually by primary school, these are reasonably reliable and can be appropriately diagnosed by a suitably qualified, clinician.
Yeah, because I suppose that's kind of the first point that you can. It's another context that's added to a child's life that
exactly.
you can start to see those difficulties popping up.
And let's be real about it, right? All kids can be hyperactive. All kids can be impulsive and inattentive, particularly when they're young. So it's about working out whether the symptoms that the child is displaying, are they developmentally excessive or developmentally inappropriate or excessive for the developmental stage that the child is. And early in childhood, that can be a bit hard to determine because when children are very young or they're infants, but as they get a little bit older, you can sort of compare to other peers and the way they're displaying, etc. And it can become more reliable, I guess.
Yeah, sure.
Yeah. So what do we know about, for people for who ADHD is not diagnosed and they're left, to their own devices without those supports in place to help them manage their symptoms? What do we know about outcomes for those people?
Yeah, look, unfortunately, they're not great. And this is why, we hope that people who are presenting with symptoms do come forward and work through diagnosis, because we know that untreated ADHD, folks are at increased risk, particularly for substance use disorders, whether that be alcohol use or, unfortunately, other drugs of abuse. We do know also, unfortunately, and perhaps in combination with that sort of substance use history, that many people in the prison system can have ADHD. We know that people who are untreated are more likely to have car accidents. We know that they're more likely to have, relationship difficulties. And unfortunately, we also know they're more likely to have, suicidal ideation, attempt suicide, or have other accidental forms of death. So, the morbidity associated with ADHD is high, but particularly high for people who are untreated.
Yeah.
And we often are saying that, ADHD is a highly treatable condition. These negative lifetime outcomes don't have to be that way. If we can get in early, diagnose well, treat well, treat appropriately, and provide all the wraparound support, then folks with ADHD can live, healthy, happy lives like you and I.
Yeah. I mean, that's a good opportunity now to start talking about some of the treatments, which is a big part of the guidelines. And I like how in the guidelines you do go through this section about, it is lifelong, and there might be, you already listed some key characteristics in each phase of life that you might see. So maybe before
often lifelong, not always. Some people will remit, but many people will carry symptoms through their life. Yes.
Yeah.
Talk to us about that part of it. For somewhere it isn't lifelong, and it does, like you said, there remit. What happens there?
Well, the symptoms can certainly change over time.
Sure.
If in adulthood you may not have the outward hyperactivity of childhood, for example, but it may be replaced by a more sort of internal restlessness that the person feels as if they can't really ever find a calm space. They feel like they're constantly sort of agitated. And in adulthood, the symptoms can be around disorganization, a lot of problems following through, procrastination, etc., which, and again, are at extreme levels. We can all procrastinate naturally.
Sure.
But we're talking about excessive levels and that are impairing.
Yeah. And can we just talk as well at this point about masking and, some of the strategies that people might develop to start masking some of their symptoms, particularly as they do get a bit older?
Yeah.
Yeah. And I mean, the term masking is, probably most often applied to girls with ADHD. And we are certainly concerned about girls and women with ADHD. So the idea there is in children, boys are more frequently diagnosed than girls. Probably international data would suggest maybe the prevalence is twice as high in boys as in
Okay.
girls.
Yeah.
But in adulthood, it's not the case. So it's parity in adulthood. So that raises a question, what happens? Is it the boys are remitting or girls are coming through and achieving diagnoses later in life?
Yeah.
And probably it's a little bit of both, but probably more likely girls are going undetected in childhood, probably because they have more of an inattentive presentation. They're more daydreamy. For example, they don't have the outward hyperactivity. They're able to socialize a little bit better and socially mask some of their perhaps behaviors or symptoms that might be a problem to them, but they're not. The public out there, or parents, teachers, is not really aware that they are a problem for the child. And then, we think, and again, we don't have great data on this, we think probably what happens is with time, as life becomes a little bit more complex, particularly study demands, probably the onset of puberty, all these things make it a little bit harder for girls to continue to mask these symptoms. And so you start to see inattention come to the fore more. Often it might look like anxiety for girls early on, but actually the driver of it is probably inattention. And then through adulthood, as life continues to pile on challenges, it becomes increasingly hard for women in this case to manage, to cope, to juggle, to do all the things that we have to do in as adults. It's sort of this trajectory, but we need much better data on it, and we need many more studies dedicated to girls and women understanding profiles and how it develops across time.
Yeah, I know, personally, I have a few friends who are at the moment on the diagnostic journey for ADHD, and actually the stimulus for that was becoming mums themselves, and having all of the resources that they had being spread so thin that there wasn't really anything left to maintain those kind of masking behaviors, and so that was the prompt to seek help and support at that point.
Yeah, and I think absolutely we know that the mental health of women who are untreated and with ADHD is not good. So we want them to get diagnoses appropriately and to get treatment, whether that be medical medication or whether it be psychological.
Yep. And what do some of those sort of interventions look like, I suppose? And I guess coming back to some of the guidelines where they are quite nicely laid out in terms of I guess we'll call them non-medication approaches. What do we know about that at the moment and what's available?
So non-medication for your listeners is really talking about, I guess, what are primarily psychological therapies. So therapies that your listeners might know, such as cognitive behavioral therapy, even others like dialectical behavior therapy, there's evidence for. But so let's try and just step through it. I guess in kids, very young kids, what we recommend is that parent and family training should be offered, because that's really important for maintaining a really strong parent-child bond, and for keeping the developing self-esteem of the child, keeping that intact and allowing it to develop as it should. We don't want kids having poor self-esteem, and we want the parent to be supported in parenting a child who can have difficult symptoms and challenging behaviors. Let's be honest. So we want the parents to be supported so that they can really raise the child and maintain that parent-child bond. So that's early in life, which is really, really important. As they move through and become a little older, they have the sort of metacognitive abilities to be able to engage in other psychological therapies like cognitive behavioral therapy. But generally, they're probably better in older adolescents and even into adults, where they can engage in perhaps cognitive restructuring or understand the ways their symptoms playing out, for example. But there's a whole range of other things too. Psychoeducation is massively important and falls within the realm of non-medical approaches, and that can be about helping the person with ADHD to understand the condition, for example, understand its causes, how it presents, can be very empowering for them. It can also be about modifying the environment, whether that be at school or the workplace, to help the person with ADHD get the most out of their cognitive abilities, so whether it be not being in a space that is cluttered and distracting for them in the workplace, whether it be taking more frequent breaks, all these things. And they will differ from person to person. So working through those with your psychologist or even your ADHD coach, which is these days an increasingly important group that are involved in helping folks with ADHD.
And I like how you went through that detail about, some of the lifestyle things. Now, I know that in the recommendations, recently we spoke to Dr. Sue McCabe, who's an occupational therapist and specializes in sleep. And I know, she's very much in the space of cerebral palsy, but increasingly in ADHD. And, supporting children, looking at environments, looking at temperature changes and how that then impacts their day and whether they're alert and set up well. Like it's a 24-hour approach, really, isn't it?
Exactly.
Movement and sleep. And,
and look, and we don't make specific recommendations about sleep interventions. There's emerging data there, but would not at the level of evidence-based recommendations. But we do say that good sleep, a healthy diet, an active life, all these things should be fundamental parts of any treatment and care plan for people of all ages. With ADHD, definitely.
For as much as, I suppose, looking after a person's mental health as well as kind of helping them to manage their symptoms, is that right?
Yeah, exactly. I mean, we know how important sleep and a healthy diet and exercise are for mental health in general. So and obviously for physical health. But you want to give people the best opportunity to be able to do the best they can, and so put all those things in place, and then on top of that, lay in the medical options or the other evidence-based, non-pharmacological options as well.
Yeah. So let's finish off with the pharmacological interventions, Mark. When should medications be considered, and what kind of outcomes do we expect from those medications?
So medications should be considered when a diagnosis is present, can be considered alongside non-pharmacological options, right? So we recommend both. In children, medication options are recommended. We make strong recommendations regarding medicines in children, and the types of medicines are what people refer to as stimulant medications. So they're medications that potentiate the levels of dopamine and noradrenaline in the brain, and these have been used since the 1950s. For ADHD, they have very, very safe profiles, very low rates of adverse events, for example. And we have strong evidence that they're safe to use in kids, adolescents, and in adults. There are also non-stimulant medications that we make recommendations about as well, and they can be used either instead of stimulants or as well as. Sometimes that will come down to preference of the individual or preference of the clinician. But yes, there are lots and lots of strong evidence around medication options.
And so, Mark, to finish off, we talked towards the start of this chat about the process for developing these guidelines and how you were able to collate all of the available evidence for interventions, but also, you said that this process highlighted a lot of areas that required further research and more evidence. So where to from here? Where do you see the kind of the priorities? It's probably a hard question, but what are the priorities for research in this area?
Yeah, look, it is a tricky question. It's one we've been giving a lot of thought to. I mean, in many ways, the development of the guideline is just the start of a journey, right?
Yeah.
The next steps are about how to implement the guideline and change practice. And that is really what we're looking at now. A big piece of what we're focusing on now is how do we configure care pathways appropriately for people with ADHD, and what is the evidence that one over another model might work best. So we promote in the guideline an interdisciplinary care model, but we know that in most cases that's not happening. Okay, maybe we're getting a little bit of that in the public health system for kids, but in the adult system where ADHD is exclusively treated by private clinicians, we're definitely not getting that. Yet we know that a holistic approach that involves perhaps a psychiatrist, a GP, a psychologist, a nurse, an OT is going to likely give us better outcomes. So we want to start advocating for that. We probably going to need changing the way Medicare is used and funded and rebated, for example, to enable GPs to play a bigger role. So they're big pieces of almost national level policy change that if we're to remove some of the health inequities, because it isn't fair that an adult should have the only option available to them to be treated in the private sector, and to get no publicly available treatment is a health inequity.
Gosh, that gives so much hope, though. Like just to know that that's the future direction, and
it's on the radar.
That's right, and that's why these things are so important.
There's huge momentum at the moment, and it's great.
It's wonderful.
And I've said time and time again that the whole guideline process has been, a massively collaborative effort across all the discipline areas that are involved in the diagnosis, management and support. The guideline has been endorsed by all the major medical colleges and allied health societies, associations. So, I think we are at a sort of rare moment when the field is on a unity ticket, and I think this does provide hope that things will improve for folks with ADHD. And and they need to. We can't go on having these disparities and health inequities. And we know the cost of ADHD to Australia is $20 billion per year. It doesn't need to be.
That's right.
No.
If we are able to treat and help people back into the workforce, be productive in the workforce, etc. It really will be for the good of the whole country.
Absolutely. So we would encourage everyone listening to, read these guidelines, share these guidelines, get the word out to as many people as possible, and let's
and the only other thing
keep
to
it moving.
Tell you guys is that we're currently producing a consumer companion guide.
Wonderful.
Because we are very, very aware that a very, very large document is not going to be
not like
suitable
reading
for everyone with ADHD to read, no matter how committed they are. So that's a sort of
wonderful,
a potted summary of the guideline, again, written by people with lived experience for people with lived experience. So look out for that.
We'll look out for it, yes. We'll keep an eye out for it as well, and we'll put all the links on our website. So, please head over to the website, researchworks.net. You'll see all the stuff that we've spoken about today and the links to the papers, and we'll keep it up to date for you as well, because this is just so important. Let's just keep up to date with all the things that are happening. I'm very sure we'll be speaking to you again soon, Mark. I'll be emailing, pestering you soon, and I'll keep an eye out on the work that's happening in this area. It's just so important. Thank you very much. Remember, head to the website and you'll see all the links that you need to know for there. But for now, I guess we should say thank you. Welcome back to a new season.
Yes. And thank you for joining us, Mark. We hope you'll come back again soon.
Yeah, you're welcome. Have a great year ahead.
You too.
Thank
Thanks.
you.
Bye.
Bye.